Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 519 of our pharmacotherapy series, which majors in chronic kidney disease. The first case reads, KAG is a 37-year-old morbidly obese, with a body mass index of 40 kilograms per meter squared, black woman who presents to the clinic with complaints of increased swelling in her extremities for the last 2 weeks, decreased urine output, and pink-colored urine. Her medical history is significant only for hypertension, which is well controlled with amlodipine 5 mg orally every day. She takes no other prescription or over-the-counter medications. Pertinent laboratory values are as follows. A serum creatinine of 2.1 mg per deciliter. The normal range is 0.6 to 1.2 mg per deciliter. Spot albumin to creatinine ratio is 1,200 mg per gram. The normal value should be less than 30 mg per gram. Urinalysis reveals 18 RBCs per high power field. The normal range is 0 to 3 RBCs per high power field. eGFR if 34 milliliters per minute per 1.73 meters squared. The nephrologist schedules a biopsy to obtain a definitive diagnosis for her new onset kidney disease. Biopsy results are as follows. Light micrograph shows a moderately large segmental area of sclerosis with capillary collapse on the upper left side of the glomerular tuft. The lower right segment is relatively normal. Electron micrograph shows diffuse epithelial cell foot process fusion with occasional loss of the epithelial cells. The other major finding is massive subendothelial hyaline deposits under the glomerular basement membrane. The pathologist's impression is focal segmental glomerulosclerosis, abbreviated as FSGS. So my first question to you reads, what is the relevance of focal segmental glomerulosclerosis, and what are the management strategies for focal segmental glomerulosclerosis? Focal segmental glomerulosclerosis is characterized by sclerotic lesions of the glomerulus, which can be either focal or segmental in nature. The development of focal segmental glomerulosclerosis may be idiopathic, primary, or secondary to other diseases, i.e., morbid obesity, sickle cell disease, congenital heart disease, and AIDS. Currently, focal segmental glomerulosclerosis is the leading cause of idiopathic nephrotic syndrome and accounts for 15% to 20% of the cases. Black patients are 2 to 4 times more likely to experience idiopathic focal segmental glomerulosclerosis than white patients, and they have a higher incidence of end-stage renal disease caused by focal segmental glomerulosclerosis. Genetic variants of the apolipoprotein L1 gene predominate in patients of African ancestry and have been identified as a major risk factor. Most patients with focal segmental glomerulosclerosis will present with proteinuria, but only about half of them will initially present with the nephrotic syndrome. Patients with the nephrotic syndrome will also likely present with hypertension, increased serum creatinine levels, and hematuria. During the early stages of focal segmental glomerulosclerosis, the symptoms may be indistinguishable from minimal change nephropathy, a glomerulopathy characterized by similar lesions within the glomeruli. A kidney biopsy is necessary for diagnosis. Predictors of increased risk of progression to end-stage renal disease include massive proteinuria, that is greater than 10 grams per day, higher serum creatinine level, that is above 1.3 milligrams per deciliter, and black race. Let's now discuss the treatment. We will begin with corticosteroids. Patient KAG should be placed on steroids, in addition to an angiotensin-converting enzyme inhibitor or angiotensin II receptor blocker and a loop diuretic, because she has focal segmental glomerulosclerosis and nephrotic syndrome. A course of corticosteroids 1 mg per kilogram per day, to a maximum dose of 80 mg, or 2 mg per kilogram every other day, to a maximum dose of 120 mg, for at least 4 weeks and for up to 4 months, with tapering of the dose over the course of 6 months after complete remission is achieved. Complete remission is defined as reduction of albuminuria 3.5 grams per deciliter. The median time to remission is 3 to 4 months. Patients whose proteinuria does not respond after a 4-month trial of therapy should be considered resistant to steroids and be rapidly tapered off over the course of 6 weeks. Let's now discuss steroid-resistant treatment. Calcineurin inhibitors, the addition of cytotoxic agents, such as cyclophosphamide or tacrolimus, may be considered for patient KAG if she is steroid-resistant, intolerant of long-term steroid therapy, severely nephrotic, frequently relapsing, or steroid-dependent. The data supporting the use of these agents in focal segmental glomerulosclerosis are limited. Retrospective studies have shown that use of cytotoxic drugs can produce complete remission in 50% of cases. Length of therapy of these agents may predict the remission rates of focal segmental glomerulosclerosis. Recent prospective studies support a longer duration of therapy. Evidence supporting the efficacy and safety of cyclosporine in focal segmental glomerulosclerosis stems from randomized controlled trials. In addition to being options for steroid-resistant patients, calcineurin inhibitors provide a steroid-sparing effect in focal segmental glomerulosclerosis steroid-sensitive patients. Cyclosporine studies are the most prevalent of the calcineurin inhibitors. Cyclosporine response is highly dependent on the previous steroid response. Complete remission rates of 73% can be seen with cyclosporine in steroid-sensitive patients. Conversely, therapy with cyclosporine doses of 5 mg per kilogram per day for 6 to 12 months has been found to be effective and can result in remission rates of up to 69% in patients resistant to steroids. The current recommendation is cyclophosphamide of 3 to 5 mg per kilogram per day in 2 divided doses. If remission is achieved, continue treatment for 1 year. However, if no remission is achieved by 6 months, discontinue cyclosporine. Limitations of cyclosporine therapy include high relapse rate, that is 23% to 100%, after withdrawal, side effect profile, nephrotoxicity, hypertension, and resistance to therapy. Studies evaluating tacrolimus as a treatment option for focal segmental glomerulosclerosis are few and lack randomized controlled trials. Current tacrolimus therapy should be initiated at 0.1 to 0.2 mg per kilogram per day in 2 divided doses. Tacrolimus has a similar side effect profile to that of cyclosporine. Sirolimus is associated with nephrotoxicity in focal segmental glomerulosclerosis and is not recommended for treatment. And now we will look at mycophenolate mofetil. Mycophenolate mofetil has the potential for a steroid-sparing effect. However, relapses are common. Mycophenolate mofetil and high-dose dexamethasone are recommended for steroid-resistant patients intolerant to cyclosporine therapy. A small study of patients with focal segmental glomerulosclerosis resistant to steroids, cytotoxic agents, or both and cyclosporine received mycophenolate mofetil for 6 months. At the end of 6 months, 44% of patients had improved proteinuria, but no patient achieved complete remission. Other studies examining mycophenolate mofetil therapy at doses of up to 2,000 mg per day have found no clinically significant effect on remission rates. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 520.